All right, our final speaker of the afternoon and of today's session is Dr. Leslie Hamilton. Dr. Hamilton is an associate professor with the University of Tennessee College of Pharmacy on their Knoxville campus. Has been there in academia at that campus since 2012. Prior to that, she was a professor with the Auburn University for a few years there as well, where she practiced there in pulmonology and critical care. Here at UT, she practices in neurology and critical care. So please give me a warm welcome to Dr. Leslie Hamilton for your last session of the day on fluid, electrolytes, and nutrition.
Thank you, Brian, for the introduction. My current practice is neurocritical care, and so I see sodium and electrolyte disorders all day long, and also a lot of my training is in nutrition support and critical care, so we'll kind of do that part at the end, but glad to be here today. Okay, I have no conflicts of interest to disclose at all. And I have kind of an agenda of what we're going to be covering today. Some things I'm going to spend more time on, some things I'm going to go a little faster on, depending on what is most important for you guys to know. But we will be spending a decent amount of time on sodium disorders. Those are some of the most difficult disorders, to making sure everybody understands the different types of hyponatremia and some of the intricacies of hypernatremia. And then we'll be finishing with the other electrolytes, and then finally with nutrition, enteral and parenteral nutrition. Okay, so our first question that we're going to go over, self-assessment question, is about fluids. And so we have a 74-year-old female, comes in with a cough, has a temperature of 102, and is lethargic. And you can start looking at some of her baseline characteristics. You see the blood pressure, she's hypotensive. Her heart rate, she's pretty tachycardic. Urine output is slowed down, white count is up, and so you're kind of thinking, looking like a sepsis picture potentially. You see some renal dysfunction, and she got a 500 cc bolus of normal saline. Her pressure went up a little bit, heart rate didn't really budge, and she has a diagnosis of pneumonia based on chest x-ray. Not really anything that's important in terms of her past medical history. So what is the best treatment option for this patient? I'm going to go ahead and have you guys poll. Should we give her some Lasix, 40 milligrams, albumin plus Levophed or norepinephrine, a liter bolus with D5W normal saline, or a liter bolus with normal saline? So if you guys can throw up cards, great. I see mostly D, and we'll get to a bit more of a discussion about this and talk about the answer in a little bit. But what you need to think about in this patient is, how do we recognize intravascular volume depletion? We talked about her clinical signs and symptoms. We saw her heart rate. We saw her blood pressure. You can look at skin turgor. Those sorts of things are some of the diagnostic criteria for someone who might be intravascularly volume depleted. We also, this is kind of setting us up to think about how, when you give a liter of fluid, depending on what type of fluid, how is it distributed in the body, and why is one type of fluid more effective than another type of fluid? And then finally, what IV fluids can we use that can maximize our intravascular volume? I remember when I was in pharmacy school, and when I still teach this information to my current pharmacy students, people usually groan thinking about how the body is divided up into the intracellular and extracellular compartments. So I'm going to make this hopefully not very painful, and we'll go through it pretty quickly. So if you think of a patient, about 60% is intracellular, and then 40% is extracellular, and then it's further divided into interstitial and intravascular. And this intravascular is our biggest target, because when someone is septic or maybe has hypovolemic shock, that's the target that we're trying to get to, is to replenish that intravascular volume. There are red blood cells in this space, and also plasma and extracellular fluid, and there's a little bit more, about 2 liters of fluid that go along with that to make up your total blood volume of about 5 liters. So if you think of your body like a gas tank, the intravascular volume is what is important and makes you go, per se. And then you guys have seen, I'm sure, many times before the Starling Curve, and looking at the measures of intravascular volume and also cardiac output. And as this is increasing, you kind of get to a level, and then it starts going back down with your cardiac output as well. So this is something that is pretty important to think about in terms of when you're replacing IV fluids, when you're thinking, Is a liter normal saline best? Is a liter of Normasol or a liter of lactated ringers the best? Why is one better than maybe a D5W combination? And so if you think about sodium chloride, lactated ringers, and Normasol. And I do have to ask, who uses Normasol or Plasmolite at their institution? Probably not tons of people. And so I'll give you just a very quick little info about that fluid because it's a bit more expensive than other fluids, but it's a very useful fluid. The sodium content is 140, so it's kind of normal as in what a body's normal sodium level would be. And it has a much lower amount of chloride in it than sodium chloride does, like normal saline does. So if you're seeing someone who gets hyperchloremic metabolic acidosis, Normasol can be or Plasmolite, it's another name for it, very similar, can be a very good fluid for those patients. So you can consider all these three are types of crystalloids. And since the sodium and chloride don't freely enter cells, if you give a liter bolus, you're going to end up giving about 250 cc's or a quarter of that bolus that's going to go into the intravascular space. However, if you might see a provider or physician wanting to do a liter bolus of D5W, only 100 cc's or 100 mLs of that is actually going to make it into the intravascular space. So it helps about thinking, how does dextrose get broken down? Since it's water and CO2, water can go freely across that membrane, which is why only 100 cc's ends up staying in where you want it to, the intravascular space. So going on to colloids, and there's a lot of different types of colloids that we use. It was great hearing our previous speaker talking about, some of the albumin issues and in renal patients, but if you give 500 cc's of albumin, it's supposed to provide 500 cc's of intravascular volume replacement. And there's different types of colloids, so packed red blood cells, PRBCs. If someone's in hemorrhagic shock, you might be using that as your colloid. Albumin is another example. Dextrose and hetastarch have really fallen out of favor, though they are used sometimes just because of the risk of renal failure. But I wanted you all to have a complete list of these. Now, we gave an example previously of 5% albumin, but you might see practitioners using 25% albumin, and it actually is going to expand the volume by 5 times the amount that you're actually giving. So if you give 100 mLs of 25% albumin, it's going to actually give you 500 mLs of intravascular volume replacement. And this can cause redistribution, which actually might end up dehydrating patients in the long term. There's really some specific patient populations that you will use this in. Patients with ascites, so more end-stage liver disease, they're getting paracenteses, removing the liters of fluid, so have a lot of ascites. And also someone who might have end-stage cancer and has pleural effusions and has problems with this, that you really want fluid redistribution to happen from those spaces, then this might be a good option to use. So as I already mentioned, hemorrhagic and septic shock are usually when you're going to see these types of fluid resuscitations happen. When about 750 mLs have been depleted from the body, that's when you start seeing the signs and symptoms of hypotension. People might be tachycardic, and then especially once they have received fluid and get a fluid bolus, then you see that improvement. Like our patient that we had in the previous case, her systolic went from like 72 to 80, so she did have an improvement. They do recommend using a central venous catheter especially when you have large volumes of fluids to replace. That's not always practical and able to happen in an emergent situation in the ER. But if you have a patient, maybe a trauma patient who needs to get 40 liters of different types of products, blood products, and also fluids, to be able to do that much that quickly, that can be recommended. Also, they do recommend you give a bolus 500 or 1,000 mLs and then watch what happens and kind of do little boluses at a time. So you may give a liter, kind of see what happens, and then give another liter and see what happens. And you might use 500 mLs instead of a liter if maybe you have someone with chronic heart failure or chronic kidney disease or a very small patient. You may start with 500 mLs versus a liter in those patients. So crystalloids are really recommended. They're a lot cheaper than colloids are. Patients can develop adverse reactions to colloids. So there's a syndrome that you may have heard of called TRALI before, T-R-A-L-I, and that's transfusion-related acute lung injury. So patients can get basically acute lung injury and ARDS from colloids, even albumin, but especially with packed red blood cells. So that can be an issue for those patients. And they really haven't found any superiority of colloids over crystalloids. So if you have a cheaper agent that's easier to get and it has fewer potential adverse reactions, that's why you'll see most practitioners ending up using crystalloids instead. If a patient may have received several liters of fluid and they still, they're starting to look puffy, they look kind of like the Michelin Man, and they're not able to keep their fluid exactly where it needs to be in the intravascular space. At that point, you may consider giving some albumin at that point to help hold the fluid a bit better in the intravascular space. And then, as we already mentioned, patients who might have very severe edema, like an ascites patient or a patient with really severe pleural effusions, the 25% albumin might be recommended in those patients. And you might see that given with a loop diuretic like furosemide. So it's kind of like a chaser, truthfully, after albumin. So they give the albumin, and then any extra volume that they want to help remove excreted by the kidneys, they will give a loop diuretic for that. So hopefully you guys have never, and this happens sometimes, working in your hospitals and in your pharmacies, if you might see an order, I need a stat liter of D5W half normal saline with 20 a K. That's not a stat order, that's maintenance fluids order. So sometimes if you work in an academic medical center where there's new medical residents there and they may be ordering fluids for their very first time, this can be something that you can help educate them on about whether you're doing fluid resuscitation with, liter boluses, or whether you're doing more of a maintenance fluid like with the dextrose half normal saline combo. The only exception to this, and this is in my intensive care unit that I work in, is we use for our maintenance fluid usually normal saline in most patients, because if someone has had a stroke or some sort of neurological injury, you want to be very careful not to let them get too hyponatremic. So you may see someone getting more normal saline, maybe even lactated ringers or Normasol with that sodium of 140. And this is an important role for you as a pharmacist as well, is to evaluate their IV fluid daily. So I might see someone that's eating and drinking just fine, or maybe enteral nutrition has been started on them, and then you still see they're getting fluids at 100 cc's an hour. That might be an intervention you can make, calling the provider saying, do we really need both, because it can end up fluid overloading a patient. So the question that you might get asked a lot is, how much fluid do you need to give patients? And so I'm going to give you some rules of thumb as we go, because the rules of thumb make it a lot easier to remember kind of when you're coming up with these patients, and also studying for your board, your BCPS exam as well. So for fluid resuscitation, you really are going to give 500 or liter boluses until their signs and symptoms improve. I might need 2 liters. Someone else, a bigger gentleman who's a lot taller than I am, may need 3 or 4 liters. So it really kind of depends on the patient how much fluid resuscitation they may need. Based on a pediatric fluid resuscitation formula, some practitioners will give 1,500 mLs for the first 20 kilos of a patient, and then 20 mLs per kilo thereafter. A lot easier way to remember that is about 30 mLs per kilo. So if you have read the surviving sepsis guidelines before and think about what a fluid bolus is considered, it's usually 30 mLs per kilo in most patients. That also tends to be what a patient's daily fluid requirement is. So for me, it's a lot easier to calculate 30 mLs per kilo than necessarily remembering the formula. Okay, so back to Our Lady, and you guys have already answered this question and did a great job. So almost overwhelmingly, I saw that you all did pick the liter bolus option D with normal saline. Remember that we don't want to give Lasix for this patient. She is fluid depleted. We do not need to give albumin nor epinephrine without trying some boluses of a crystalloid. This is more of a maintenance fluid, and then you guys did great choosing the correct fluid option. Okay, so we're going to move on to plasma osmolality, and this becomes a big problem particularly in a neurologic or traumatic ICU. or even maybe on your floors. I see it a lot with mannitol. So if someone's getting mannitol, you have to be very careful with their osmolality, the patient's osmolality. And this also is really important in terms of fluids. So for you guys working on the floors or in your pharmacies, you may see different things get ordered that they're very, very hypotonic and have a low osmolality, or very hypertonic and have a high one. And depending on the patient, that may or may not be appropriate for them. So you have to be very careful, because too high of an osmolality can cause dehydration, basically drying out of the cells, and a low one can cause swelling. So you want to try to keep it in a nice range, around somewhere between like 280 and 300 is, for most hospitals, normal range for osmolality. So for your normal types of fluids, like normal saline that are isotonic, there's not really any fluid shift, because there's not a difference in the osmotic gradient. But if you have someone who maybe has traumatic brain injury, or even very severe low sodium, so very severe hyponatremia, they may be receiving hypertonic IV fluid, and you have to be very careful to use it only for a particular period of time, and watch their sodium and their osmoles very closely to make sure you're not going up too quickly. Hypotonic IV fluid can be just as bad, if not worse, if the osmoles of the fluid is less than 150, or sorry, excuse me, if the osmoles of the patient are less than 150 milliosmoles per kilo, then it can end up causing hemolysis of the red blood cells. So this can be a problem. Have you guys ever seen an order for quarter normal saline before in your institutions? I see a few hands. And so we're going to talk about some of the problems with quarter normal saline and some solutions that you can suggest to your providers at your institutions if that is recommended. We're going to skip the calculations of the osmolarities, but that is in your book. And then we're going to go on to our next case and then describe some of the different fluids and the different osmolalities that you have. So we have a 72-year-old female with hypertension who started HCTZ 3 weeks ago and has signs of dizziness, fatigue, and nausea. She's also hypotensive and tachycardic, and her sodium is 116. So I'm sure you guys may have seen this in the hospital. You have more of an elderly patient admitted, they just started hydrochlorothiazide, and boom, they come in with a low sodium. What you need to think about as a practitioner is she seizing? No, she's not at this point, but she has some dizziness, fatigue, and nausea. That helps you decide how aggressive you're going to be, because if a patient's in a coma and they're seizing, you're going to push more towards one type of intervention versus another. So based on your guys' thoughts, what would you do for this patient, if you'll show your cards for me? So would you give normal saline at 100 cc's an hour, a 500 cc normal saline bolus, 3% sodium chloride, or 23.4% sodium chloride? I see mostly B's. Great. Okay, we're going to go on and go on to our next question. What is the treatment goal for the first 24 hours in correcting her sodium? And her initial value is 116. 140, 132, 126, or keep her 116 to 120. You guys will show your cards for me as well. I see lots of greens, which is great, and we'll talk about the different rates by which you can increase someone's sodium and what is a safe rate to go up. This is a question, when I recently took my critical care boards that were just offered for the first time this year, there were several questions about how fast you could raise someone's sodium, and I remember there's lots of things about sodium disorders on there. So symptoms of hyponatremia, and this patient, she had the nausea and malaise. Then you start getting down to headache and lethargy, and then 115, then you may see seizures and coma as well. Now, in some patients, they may be a lot more sensitive to this, and so they may have seizures and coma at a level of 120 versus a level of 115. I'm sorry, it looks like maybe you're not being able to find it in the book. I see some people. It's not in there? Okay. Okay. Some of the slides are missing. Interesting. Okay, well, we'll keep on going, and I'll make sure that you get, I just noticed, I see some people have a handout. Okay, online version's correct, I hear. So sorry about that. I just saw people flipping around and wanted to check. Okay, the next question about The next thing to think about in hyponatremia are patients who have severe hyperglycemia. So I will never forget when several years ago, I had a patient who came in DKA, and their sodium was 120, and the physician immediately wanted to start hypertonic saline in this patient, but their glucose was 1,000. So you need to take into account someone's glucose, because you can correct someone's sodium for their glucose, and then it actually ends up being a pseudo-hyponatremia. So that's something that's really important to think about in patients with hyponatremia, what their glucose is. So as a quick review, there are 3 types of hyponatremia: low volume or hypovolemic, normal volume or euvolemic, and then hypervolemic hyponatremia. And if you think about it, I think truthfully the easiest one to think about is probably hypovolemic. Someone may have had nausea and vomiting or diarrhea, they may have gotten a trauma, and so they've lost a lot of volume, so then they have a low sodium from that. Something that you can add to this is patients with cerebral salt wasting. So if any of you have worked with neurological patients who may have a stroke or subarachnoid hemorrhage, they can also experience hypovolemic hyponatremia. Hypervolemic also is not too hard conceptually to think about. Patients with poor kidney function or patients with heart failure, they are fluid overloaded, and so basically their water stores are a lot more, and it's making their sodium look low just because their volume overloaded. And euvolemic is usually the hardest, and a lot of times it's caused by SAADH. And us as pharmacists, if you get a consult, please help look at medications for someone's hyponatremia, which you might get asked. Then there's a lot of different medications that can cause SAADH. So these are kind of our main causes, just as a review. With hypovolemic hyponatremia, what can happen is that a patient who is hypovolemic, their ADH secretion changes. And so once you restore their intravascular volume, then that secretion slows. And so you have to be very careful making sure that you don't correct too quickly the sodium in these patients. Okay, on to the next slide, which is going to answer our questions back. And sorry if these are not in your slides that you have in your book. That you guys were correct in that normal saline is the correct option. This, I want you to think about, this high amount of sodium chloride is really only used for intracranial pressure control in patients with traumatic brain injury, so this really should never be used otherwise. And 3% is an option, but remember, she's not seizing and she's not in a coma, so we can try to do a fluid bolus first. And I think the other obvious thing is you need to stop her hydrochlorothiazide. That's something that's not included in the question, but stop the drug that caused it. Another thing to think about, I work with a lot of stroke patients, and so this example of this, in this case, is someone who's had a recent stroke, is non-communicative, has expressive aphasia, and they're started on enteral nutrition, which is great, and then you see their sodium start crawling up in this patient. So I want us to think about, as we, in a little bit when we get to hypernatremia, about why this happens, because a lot of times it's just because they get their volume dry and volume down. Okay, back to the same slide with hyponatremia. We already talked about the causes of hyponatremia. Now we're going to talk about how you fix them. So for hypovolemic, I think that everyone could very easily agree you need to give them more volume. If you have hypervolemic, you need to restrict what they're intaking and trying to get rid of the underlying cause of the fluid, and maybe if they need dialysis or need diuretics if they have heart failure. And then we're also going to talk about some of the strategies in euvolemic, and then the Vaptans, which we will talk about right now. So the Vaptans are Conivaptan and Tolvaptan. Has anyone in here used the Vaptans before? I'm sure several people probably have. Great. And what they are arginine vasopressor receptor antagonists. And so what they end up doing is helping, they are called aquaretics, so they help patients basically excrete water without all the electrolytes in there. So if you've ever used them before, when I've used them sometimes in patients, I might see a patient pee 6 to 8 liters of fluid, and it's clear as water because they're holding on to all of their sodium and all their other electrolytes. Remember, though, you only want to use this in hypervolemic and euvolemic because it does not make sense to use it in hypovolemic hyponatremia, because in those patients, you want to give them more volume back, not take it away from them. So that's one of the great interventions a pharmacist can make. If you see an order for one of these, help a provider look at their ins and outs and look at the patient and make sure it's the appropriate therapy for those patients. Things to remember is that these drugs, especially Conivaptan, which is the IV form, have a lot of drug interactions. They work on CYP3A4, and so they're with statins and several other medications. There are going to be drug interactions. And even though you're supposed to do fluid restriction with euvolemic and hypervolemic hyponatremia, if you do fluid restriction plus the Vaptan, it can end up making your sodium correct a little bit too quickly. So just be careful with that. Some patients have a more exaggerated response than others. One last thing that I'll say is that kind of goes along with the top part. There's not really any evidence of improved clinical outcomes. It makes us feel better, though, a lot of times to see someone's sodium not 120. You'll see it up at 130 for patients. So if you have someone who comes in with chronic heart failure and they live at a sodium of 118, this is not someone that you're going to want to be really using these Vaptans in, because they're chronically at 118. Even though there is an indication that you can use these, you have to be really careful, because you don't want to kind of upturn the apple cart if that's where someone's normal sodium is for them. So there's a little bit of controversy with that. Okay, we'll finish up with hypertonic saline, and then very quickly we're going to then we'll move on to hypotonic fluid. So hypertonic saline, the main uses are going to be in patients with really severe neurologic injury. Sometimes patients have a symptomatic hyponatremia, and it's usually acute. I had a patient very recently. There's some new oncology drugs that I'm not an oncology specialist at all, but I kind of had to read about them a bit, that can really deplete your sodium and your potassium very acutely. So maybe as some of these new drugs are coming on the market, keep a close eye out for patients that might have electrolyte disturbances from them. Hypertonic saline is not for chronic asymptomatic hyponatremia. So for your patient with chronic heart failure who comes in with a sodium of 118 and has no symptoms, they just happen to have a sodium of 118 that they might find incidentally on admission, this is where you don't want to use hypertonic saline. As we already mentioned, be very careful with patients who also have DKA or very severe, maybe HSS, very severe hyperglycemia, because they probably have a fictitious hyponatremia. And then also with heart failure, you have to think, is this a chronic hyponatremia for them? And you really use your clinical judgment with that, whether you want to use hypertonic saline or not. So if any of you guys work with kidney disease patients, you'll see they'll put patients on bicarb drips a lot. And a problem I've seen at our institution before is maybe with some of the newer providers, they want to do maybe 3 amps of bicarb, so 150 milliequivalents of sodium bicarb, and they want to put it with normal saline. So this is an error that you can help prevent with those patients. Maybe your institution may put it in sterile water, maybe they'll put it in dextrose, whatever your institution's policy is. But that's making sure you're not making a hypertonic solution by accident. So that's just something that you need to keep a close eye out for. So as our question already addressed just a little bit ago, and most of you guys all got this correct, is you really want to have no more of an increase than 10 to 12 milliequivalents in a day for your increase in your sodium. Now, if someone's seizing and their sodium's 105, I had someone with a sodium of 98 before, and that's one of the lowest I've ever seen, and it's really scary. And so at the beginning, you can take it up by 1 milliequivalent per liter per hour, but then you need to slow down to 0.5 milliequivalents per liter per hour, kind of as it's starting to go up. So you need to treat until patient's symptoms stop, until they get into a safe range, or you've reached that 10 to 12 milliequivalents per liter in 24 hours. So maybe if someone has a sodium of 105, your goal is going to be 115 for that day. And then the next day it may be 125, kind of as you're going up in increments, because you want to prevent the pontine myelinolysis, which we'll get to in just a second. So this is a review of what we just kind of mentioned, the 10 to 12 milliequivalents per liter in 24 hours. And I want you to think, if you can kind of grasp what exactly central pontine myelinolysis is. I've only seen it happen, thank goodness, in only 1 or 2 patients. But it's basically like acute MS, that you are taking the myelin sheath is coming off of the patients, of their neural cells, and they completely have lost that myelin, and then it really affects conduction in the brain. So it's a really, really serious outcome, and if you are very judicious with your use of hypertonic saline or increasing patient sodiums, then this can be prevented. So as kind of another kind of take-home point, the highest risk patients are people with really, that have low sodiums, but it's a really chronic low sodium. And so be very gentle and very careful when you are correcting those patients' sodiums. Okay, so you guys did great because I've already asked this question, so everyone pretty much got that right. Our initial value was 116, so an increase in 10 gets you to 126, which is a safe rate and max change for this patient. I promise we're almost done with hyponatremia and fluids. You guys, I know you were like, I have been here all day long and learning about fluids. I know it's not the most exciting topic. I'm trying to make it as exciting as I can for you. So we're going to finish up a little bit with hypotonic fluid, and this is kind of the question I alluded to a little bit ago about quarter normal saline or 0.225% normal saline. And if you think about what a patient's normal osmoles are in their body, it's around 280 to 300. Then you think about the sometimes if maybe an institution has run out of 5% albumin, they're like, we can just dilute down 25%. That can be really, really bad because it ends up bringing the osmolarity of the solution down to 60, which can really, really quickly cause cell hemolysis. Quarter normal saline also has a very low osmolarity, so when you kind of look at it in the osmolarity standpoint, then you think, man, this can really cause a problem. So if someone does have hypernatremia and you do need to think about using hypotonic fluid, some people might want to order water because that's what you'll give. But remember, you don't give water IV. It's given in free water is given in different forms. So you can potentially give this, and if they're not NPO, nothing by mouth, then D5W is a great option. But you're going to get pushback, and I do too, of practitioners who have a patient, her glucose is 600, and so they may not be wanting to do a dextrose solution just because of how high the glucose is. But the best way to do it is have a patient drink water or get enteral flushes of free water. And I always laugh. I have to explain to my students when I have them on rotation, free water is not a special type of water. It is just water. And so they always think it's some sort of special solution, but it's just water. So if you see an order for quarter normal saline, if you have some leeway to work with the physician or the advanced level practitioner who's prescribing it, see if you can add dextrose in there because it's going to help your osmolarity. If they do want to use quarter normal saline, see if you can add dextrose to it. And even if you put a little bit of potassium with the quarter normal saline, that helps your osmolarity and helps prevent that cell lysis. So there's some different options that you can recommend, and then enteral water is the best case scenario. When I was a resident, we did some testing on a few patients looking at a patient's LDH, which is a value that you can get, and looking at cell lysis. And because we were kind of studying, should we give quarter normal saline or should we not? And it's amazing that something we thought may be safe, there was a lot more cell lysis than we thought. So just give it some serious thought when you see an order in a patient who has hypernatremia. So the same thing with hypernatremia. If you can remember the range 10 to 12, it's great. It's how fast you want to bring it up and also how fast you want to bring it down. It is for a different reason, though. You might have cell lysis or instead of the myelinolysis that happens with hyponatremia. And when you are replacing their water deficit, which we'll talk about in just a second, you really want to replace it slowly. So just as patients did not get hyponatremic, usually it's going to happen over a few days. Same thing with hypernatremia. It's usually going to also happen a few days. So don't be super, super aggressive when replacing it. So there's this formula that I promise you don't have to memorize, because if you use Lexicomp or Micromedics or Hippocrates, any of those tools, it's in there. And so you can just pull up that formula and calculate a water deficit. So this might be a question that you might get on rounds or in your clinic setting is, man, this patient, how watered down are they? And so you can calculate and see how far they are in liters and then follow their replacement. So the general rule of thumb is, let's say someone has a water deficit of 2 liters. So you have their current sodium, what their goal sodium is, and in most institutions will tell you, in most guidelines, that it's safe to replace about half of that in the first 24 hours and the second half of that over the next 24 hours. So if you're going to give you want to give a liter of free water over the first day, you might give 250 mLs of free water Q6 hours to get your liter for the first day, and then you might do the same the next day. So that's just kind of an example on how it's safe to replace water without taking it down too rapidly. So our lady that we had who had a stroke, we talked about this a minute ago, and maybe what the best option would be in this patient. So I mentioned the scenario, but I didn't give you the different options. So our options are sterile water, and we have D5W, we have D5W quarter normal, and we have free water per peg tube, 200 cc's every 6 hours. So if you guys can put up your cards for me. Awesome. I'm seeing lots of yellow and D's. Great. So best as we learn, and when we talk about nutrition in a few minutes, if your gut works, use it. She has an enteral feeding tube, is getting tube feed, so might as well make use of this free water. Both the D5W and the D5W quarter normal are not incorrect, but they're not the best answer. And then as you hopefully had the same groan that I do, oh my gosh, sterile water, no, that is definitely not our option, because that's not something that we will do. Okay. And it's just as a preventative thing that you can do, if you happen to work with dietitians or in a nutrition support setting, maybe on your floor or in your ICU, if you work in the ICU, you can really work with a dietitian and the team to make sure that a situation like that doesn't happen, so that they're getting enough volume on the front end versus having to fix it on the back end if you're giving them too concentrated of a tube feed. And we'll get to that point in a little bit when we get to nutrition. But it's just, I wanted to point out that it is something that's preventable, and especially in patients who may be in kids or in patients who have some sort of neurological disease that they can't actually communicate to you, I'm thirsty, and all you might see is their sodium level go up. Okay. So we're going to move on to potassium. So you're like, whew, get rid of all the sodium disorders. It takes a while to go through because it's really complicated, and even though I've been dealing with sodium stuff for a while, you still have to think through it because it can really trip people up. So we're going to move on to potassium and kind of talk about some of the ways in terms of replacing potassium, and also if someone has hyperkalemia, how you fix this. So luckily potassium is a little bit easier, I think, than sodium. So potassium, as you guys I'm sure are very aware, it is an intracellular cation, and you really have this balance that happens between these compartments, thinking about beta stimulation, about insulin, and then these shifts that happens in and out of cells. And so it makes sense when you think about the treatments for hyperkalemia. Some of them are, albuterol that you might use working on your betas. You will use insulin because it can help shift. And then also and this is more than we're going to talk about necessarily today, the patient is acidotic or alkalotic, they can have a lot of changes in their potassium just in the shifts. And so that's something else kind of thinking, it makes sense that these are the things that control the homeostasis. So a lot of times, hypokalemia, which is, I guess, technically defined by potassium less than 3.5, it's really very rarely caused because someone is intaking less potassium because of decreased kidney excretion. So there's several different causes that you might commonly see. Patients might have this shift in potassium because their pH changes. Their pH goes up. They got a huge load of insulin, and so that may change the shifting in the cells for that. They might be stressed, might be in ICU and be septic. And then hypothermia. So if any of your institutions use therapeutic hypothermia, both for post-cardiac arrest or also maybe for traumatic brain injury or subarachnoid patients, you might know that it's really complicated in patients being cooled because their electrolytes shift a lot, and so you have to be really careful, especially potassium with one of those. Be very careful with that. GI loss is a common one that you may see. Someone might be having really severe diarrhea. Diuretics are an obvious cause, so using those loop diuretics that patients can get pretty hypokalemic. And then low magnesium, remember that magnesium is a cofactor for potassium. So if your mag is low and your K is low, you're not going to fix your K until you fix your mag. Anecdotally, a few weeks ago, I had a patient on I mentioned this a minute ago, a new chemo medicine called afatinib, and I hadn't really heard of it much before. And her potassium presentation was 1.9. It's the lowest potassium I have ever seen before. So that kind of makes me think, there's some of these newer drugs that may be coming out that we may not know much about as a kind of a general pharmacist. Be very careful and look into those agents, because that's something that I learned pretty recently about a new cause for hypokalemia. So how much do you replace in patients? And what your potassium replacement is going to be guided on, of course, your plasma level. So I'm sure many of you may have heard this little trick before. Usually every 0.1 you want your potassium to go up, you'll give 10 milliequivalents. So that's one of the easiest ways to remember, because I remember when I first graduated pharmacy school and was a resident, hadn't had much experience replacing electrolytes before. And so, if someone's potassium is 3.6 and you want it to be 4, giving 40 milliequivalents is how that kind of works out. So that's a good rule of thumb. And another good rule of thumb, too, is if someone has renal dysfunction, a lot of times you can cut the dose in half just to be on the safe side. Remember, though, potassium is used in lethal injection in some places, and so that gives you a healthy awareness that you don't need to run potassium too quickly or give too much, because it can end up having very severe cardiac implications. So they do recommend to run potassium usually about 10 up to 20 milliequivalents an hour. In an emergent situation, you can run it a little bit faster, but they should have potentially have a central line and definitely be on continuous EKG monitoring to make sure that you're not causing some sort of arrhythmia with that. If a patient can take oral or enteral, so some of the little cups of potassium, or even though they're huge, the tablets for potassium, that is the best way to replace potassium. But if not, using IV, patients, I'm sure at your institutions as well, usually complain because it burns quite a bit when it goes in. So try to use oral if you can. And then if you do have peripheral IV, the max concentration of the potassium in the fluid that you're giving is 60 milliequivalents per liter, but hopefully you don't have to get to that point. So some things to think about. These are some more kind of clinical pearls. And when you see someone's labs, and they just don't look right to you, so they've been rocking along and they've had a potassium of 3.5, and all of a sudden, man, their potassium is 6.5. That's weird, and they don't have renal failure. So that's a case that you might need to think about is, did the blood hemolyze? Did it sit on the counter for 4 hours before it got sent down to the lab and maybe hemolyzed? Or so that's something to kind of think about as we're shifting from hypokalemia to hyperkalemia, is use your clinical intuition and think, this doesn't make sense for this patient. Is this true or not? Potassium can be artificially elevated if it's a serum draw rather than a plasma draw. But regardless, you can have them redraw labs, no big deal. But if you're seeing EKG changes, that's where you need to start getting very worried. Or if a patient's potassium is greater than 6.5 and maybe their creatinine is starting to go up and it clinically makes sense, they're probably hyperkalemic. If it's not as urgent and there's no EKG changes, Kayexalate is an option. And then if they are having EKG changes, especially those peak T waves, which are very common sometimes with severe hyperkalemia, then you need to be thinking about a more urgent treatment. So calcium gluconate is not always indicated in every patient, but if you're going to be giving a lot of medications that are going to shift potassium, or you're going to be excreting a lot of potassium, calcium gluconate will help stabilize your cardiac membrane to make sure those shifts in potassium don't irritate your cardiac membrane and cause some sort of life-threatening arrhythmia. Something, though, to be careful about, patients who are on digoxin, there is some literature that you should not give calcium to patients in digoxin because it can actually worsen cardiac arrhythmias. So that's something that's kind of clinically controversial, but just keep that in the back of your mind. You might be a little bit more careful if they if they are on DIG. And sometimes I know when I see, maybe a new provider and they order, they look maybe at UpToDate and order calcium and, every single step of the algorithm. If their potassium's 5.2, they probably don't need calcium. You're not going to be having to use much to shift the potassium. And so also you can use your clinical intuition and judgment on that. Different options are insulin, which will help move your potassium intracellularly, and you can give with glucose to prevent hypoglycemia, but remember, it's not going to happen right away. And another thing to think about too is if a patient already is very hyperglycemic, don't make it worse by, you don't have to give extra dextrose with that. Sodium bicarb, you can also give, even though there's been a little bit of a shortage recently on bicarb, but you can give that. You might see that work. And then high-dose albuterol, which is not normally as effective as some of the other options. A lot of people won't respond, and so that's something that's a little bit more controversial. The best way to get rid of potassium quickly is dialysis. So if someone already happens to have a VAS cath in place, or maybe a fistula, as our previous speaker mentioned, and they might just need to be dialyzed. That's the best way, but you're not going to always throw in the central line and quickly dialyze someone for hyperkalemia. You'll try to use the other agents first. Other things to think about are diuretics, especially if their kidneys are working. So if they're an end-stage renal patient, loop diuretics are probably not going to work for them. But if someone, for some reason, maybe has some acute kidney injury, they still have some residual renal function, loop diuretics may be a good option. Kayexalate, oral, and unfortunately for our nursing colleagues, sometimes as a retention enema if someone's not able to take this orally, but it can be given as a retention enema, and then also dialysis as well. Kayexalate and Sorbitol, back several years ago when I was graduating from pharmacy school, there was controversy about Sorbitol and what kind of GI issues that it might cause. So luckily they have a lower amount of Sorbitol, which Sorbitol helps, helps that potassium get excreted as someone is having the bowel movement to remove the potassium. And there was this incidence of colonic necrosis, but luckily it's pretty rare with the formulation we have now, but you still may see reports or maybe have clinicians who are hesitant to use Kayexalate for this reason. If patients do have kidney or heart failure, especially if they're having issues with their sodium already, you might want to be careful with Kayexalate because of this issue. And there's a newer drug that I put in your handbook. It's not in the slides per se. It's called Hyponatremia or Vaptans, which just really came on the market kind of the end of December, beginning of January. So there's a new exchange resin that is out. And it's kind of funny as well. Kayexalate is kind of like Tylenol and aspirin. It was pretty much grandfathered in terms of the FDA approval. It was approved back in 1958, and they really haven't had to go back and demonstrate efficacy. And even though we talked about sorbitol, and even though they have lower amounts of sorbitol, that there's in the American Journal of Medicine back in 2013, they still said that even if it doesn't have sorbitol, that it may cause GI injury. So thinking about all your other options, if you can use insulin or bicarb, dialysis, diuretics, they may be just as effective, but kind of remember some of the downsides of Kayexalate. A few more clinical pearls on calcium. We've already mentioned this risk of calcium if someone's on digoxin, but one thing that's important to think about, especially as we live in this world of shortages, and so you might have calcium gluconate but not have chloride, or vice versa, that 10 mLs of 10% of calcium gluconate for 1 gram is 90 milligrams of elemental calcium, but chloride is a whole lot more of elemental calcium. So this can be a problem sometimes for hypokalemia, or if you're responding to a code blue, depending on what types of calcium you might have. Be really careful, and you can help make those interventions just because the calcium amounts are quite different. And another common misconception that you can help correct is that calcium doesn't actually touch potassium at all. All it's doing is stabilizing your cardiac membrane. So some people might just have the thought, we use it for hyperkalemia. Well, it's not, because it gets rid of potassium. It just helps your heart out. Okay, so the other electrolytes we're going to talk very briefly about And they wanted me to concentrate more on sodium and potassium. And I know in renal failure, you guys talked a lot more about some of the binders for hyperphosphatemia. So we're not going to talk about high phosphorus today. But MAG, as we already mentioned, is really important in patients who have hypokalemia. So making sure to give these patients who have low potassium, you need to replace their magnesium first. So if you have a magnesium of 1.2 and a potassium of 3.2, give your magnesium and then give your potassium right afterwards. If there's symptomatic, 1 to 4 grams IV slowly, and it's usually recommended to administer magnesium a gram an hour to help prevent hypotension. And as you guys know, magnesium is a drug of choice, for torsades, and so you can give it a lot quicker if in torsades. And then just another kind of a random indication for those of you who work with women and children's, magnesium is what helps with preeclampsia and eclampsia too, and so they'll give much higher doses of magnesium for that indication. Magnesium comes as mag oxide, and it comes as mag sulfate, is the IV formulation that's most commonly used. And there's another trick that I've kind of learned along the way with magnesium. Usually for every 0.1 that you want to give, increase of your magnesium, you can give a gram of magnesium sulfate to help accomplish that. So if your goal magnesium is 2 and your magnesium currently in your patient is 1.8, you can give 2 grams of magnesium sulfate to help accomplish your magnesium replacement. So hopefully that trick might help you. That's something that I teach my students. It just helps them remember a little bit easier. Luckily, though, magnesium has a really wide therapeutic index, and so compared to potassium, if someone overdosed on magnesium, it would be probably okay because there's a lot more room before you start having toxicity for magnesium. It's really when you get levels of 5 and 6 that you have problems, not at 2 and 3. Phosphorus, as I already mentioned, we're not going to talk about hyperphosphatemia because that's really covered in your renal disease stuff. Our previous speaker just talked about phosphate binders, so we won't go over that. But really, I want you to think about hypophosphatemia, patients who I want you kind of to think of a clinical picture. A patient who might be malnourished may have end-stage HIV. They might have cancer and have undergone chemotherapy and have a poor appetite, and also alcoholics. This can happen too. So I want you to think of a malnourished patient, whether it's by choice, maybe drinking alcohol, or maybe they have a disease state that they're just not hungry and not intaking things. Patients can have refeeding syndrome, which can be very, very scary. So as soon as you start giving those patients dextrose, their body starts to utilize their phosphorus and their potassium and their magnesium and calcium to help utilize that glucose, and it brings your phosphorus really, really quickly down. And remember, the P in ATP is phosphate. So if you're trying to make this energy and your phosphorus is very low, then you can end up having a lot of problems. I've seen patients on the ventilator before come in, have refeeding syndrome, and really struggle. The respiratory therapists and the providers struggle to ventilate them adequately because they're having problems with their phosphorus. So this is a good intervention pharmacists can make. It's usually dosed in millimoles IV, and there are like Nutrifos packets and Kphos and other types of packets and tablets, but they're not as well absorbed, or they're not. They can cause GI upset as well. So those are things to kind of remember. And there's more detail in your chapter versus the slides about phosphorus for further reading. And finally, we're going to finish up with calcium before we move on to nutrition in just a little bit. For hypokalemia, remember, as our previous speaker just mentioned, you need to also look at their albumin. So if their albumin is 1.5 and their calcium is 7.5, it's going to probably correct to just fine. So albumin is really important with drugs like phenytoin, and also for calcium, to making sure that you're correcting it to look and see if someone is really hypocalcemic. If someone is asymptomatic and it's associated with low albumin, it doesn't need to be replaced, and it's probably okay. Asymptomatic hypocalcemia, you can give things like TUMS, like oral calcium carbonate. And as we mentioned earlier, the differences between calcium gluconate and calcium chloride and how much more elemental calcium is in calcium chloride, you should not give or recommend calcium chloride to be given IV just because it can cause limb ischemia. Okay, finishing up, I know, take a stretch, we're almost done. We're going to finish nutrition and we'll get you guys on your evening so you can go have dinner in just a little bit. So shortages, I'm sure your institutions are have struggled with this just as much as mine has, especially we have not been able to get much potassium phosphate in quite a long time. So if you happen to be a clinical coordinator or maybe a more an administrative role, that you're helping with the ordering and the distribution of these drugs, really try to restrict it for patients who need it the most. So our pediatric and neonatal patients who need TPNs, which we'll talk about in just a minute, they need to be able to have phosphate in their TPNs. ICU patients with refeeding syndrome, or patients with very, very low phosphoruses, maybe even less than 1, may need to be able to have access to phosphorus. And if someone happens to be on propofol or is getting intralipids like as part of their IV nutrition, there is a little bit of phosphorus in there, so you might be able to get by a little bit because you're getting a little bit of phosphorus. So if someone can take oral phosphorus, even though it's not as well absorbed, try to kind of reserve it for those patients. But luckily, I think the shortage is easing a little bit. Calcium also, there's been some shortages on and off. If you don't have any gluconate, don't add calcium chloride to parenteral nutrition because it can precipitate with phosphorus like nobody's business. It will cause crystals like that. So you can pick an electrolyte product that's like a multi-electrolyte product to use instead. And they really people have wondered if you can kind of dilute calcium chloride and give it peripherally, but they don't really know, and you don't really want to chance limb ischemia if people don't really know. So you have to be very careful and maybe use oral or try to reserve your calcium gluconate for patients who really do need it. Okay, you've made it. We have our last part, and we're almost have about 20 minutes left, and we'll get finished. So I'm sorry, but we've had to cover a lot of information in this talk because we could talk about electrolytes and nutrition for a very long time. So I'll give you the highlights of the most important things with nutrition as we finish. So if I can have you remember 2 things. If your gut works, use it. So if you work at an institution where there's a lot of parenteral nutrition, you can help be a steward of that. And if someone just needs to have a feeding tube placed, advocate for that. If their gut works, use it because that's the best for those patients. And if someone is only going to be NPO for 2 days, let's say, really discourage those patients from being started on parenteral nutrition because the literature shows that there is no benefit unless someone is NPO for 7 days to starting this parenteral nutrition. There's a few rare exceptions if there's really big GI surgery and some surgical issues, but for the most part, gut works, use it, and hold off on parenteral nutrition for 7 days. And there's been some recent trials in kids and also adults looking at early versus late parenteral nutrition. And really, they keep on telling us, as our guidelines say, is to really try not to use parenteral unless you have to. So a previous institution I was at, I remember us seeing a lot more parenteral nutrition, and really you can help if there's surgeons or physicians that are comfortable placing post-pyloric feeding tubes, so going into the duodenum, that can alleviate a lot of problems that patients may have with gastric feedings. So they might have better tolerance of these feedings, less aspiration, but these duodenal tubes can clog a little bit easier. And then duodenal tubes or post-pyloric tubes must also the nutrition needs to be delivered by a continuous infusion versus bolus feedings. In a hospital setting, usually patients are going to have continuous enteral nutrition versus if any of you work in an ambulatory or long-term care patients who may have a PEG tube, they may be getting more intermittent boluses because it's easier for them and also for the family versus being hooked up to an IV pump all day. So our enteral formulations, there's some more examples in the actual book chapter, but for the most part, what you guys need to know about nutrition in terms of for the BCPS exam is that for most patients who have normal digestive processes, like no Crohn's disease, no issues like pancreatitis, you want to use an intact or polymeric formula for patients with normal processes. There's some different types of formula that are basically more broken down. That's kind of what an elemental formula is for people who may have short bowel syndrome. So if you happen to work with kids who may have had necrotizing enterocolitis as a baby, or even as they get to adults and have short bowel syndrome, they might need a different type of formula. Most tube feeds are formulated to be between 1 to 2 kilocalories per ml. So luckily for enteral nutrition, it's a lot easier to calculate your calories with it because it's basically set for you. Your volume is set, and you just need to adjust your rate depending on what your patient's needs are. There are some specialty formulas. If someone has renal disease, as our previous speaker mentioned, you might need to have reduced amounts of proteins and electrolytes. For pulmonary and diabetic patients, you're going to want to have more fat and fewer carbohydrates. Remember, carbohydrates get broken down into CO2, so it's bad for people with chronic lung disease. And then diabetic patients, they don't need as many carbs. You might want to be restricting their carbs a little bit more, and so you'll be looking for formulas that have that. There's a few more examples when we get to calculations for parenteral nutrition on the different requirements, but I'll tell you that in most patients, and if you're trying to make things easier for yourself to remember we talked about 30 mLs per kilo is a general fluid requirement for most patients. That's the same for calorie requirements too, so you can remember 30 and it will help you out. Most patients require between 25 and 35 kilocalories per kilo. 30 is right in the middle of that range. It makes it a little bit easier to remember. So if we had a typical, at least in Tennessee, 60 kilograms is not typical. Ours is probably more 80 to 90 kilograms in our patients, just by virtue of being in the South. But if we had a 60 kilogram patient, and let's say their requirements we were going to do is 25 kilocalories per kilo, nice easy calculation comes out to 1,500 kilocalories. And there's lots of different formulas, replete with fiber as an example, UltraCal, that provide 1 kilocalorie per ml. So all you have to do is look at what your calorie requirements are, what your mLs are, divide it by 24 hours, and boom, there you have your tube feeding rate. So it's not too bad. Now, I think most nurses would cringe if you ordered 62.5 mLs per hour of a tube feeding rate. So, be judicious with that and round to either 60 or 65. You can start at a slow rate and then titrate up to your goal of what that is. So this is a very, basic kind of oversimplified formula, but it's nice when you're using a formula that is 1 kilocalorie per ml because it makes it really easy to calculate when you're picking your solutions for your patients. And it will make sense to you. The renal formulas are more concentrated because they usually need less volume. So most of the renal formulas are 2 kilocalorie per kilo, and then there's some random ones in between that are 1.5 kilocalories per kilo. Now, like our stroke patient in our example we had earlier, remember you don't want them to get dehydrated because sometimes even if you could give them all the volume you wanted to via tube feeds, you might give them too many calories. So sometimes you'll have to add water along with their tube feeds. So on our example, there is 830 mLs of water per liter. So the patient is getting, that many kilocalories per day. And so we need to give them a little bit of extra water per day. And so you can order, or the dietitian or physician can order a little extra water per feeding tube every 6 hours. Or sometimes patients, they might want to run it continuously if they're in the hospital and divide that hourly instead of every 6 hours. So again, 30 mLs per kilo per day for most patients. This example, we had a little bit less, and so we targeted a little bit less in that patient. So even though enteral nutrition is our gold standard, there are a few complications just for us to think about. So for any good patient care, you want your head of bed to be 30 to 45 degrees, and so that way it prevents aspiration. There's been a lot of controversy about gastric residuals. Some institutions still check them diligently and hold tube feeds if they're too high. There's really been evidence that came out several years ago that it really doesn't matter and doesn't predict how well patients are tolerating their tube feeds, and so some institutions really don't measure them anymore unless maybe someone's vomiting tube feeds and obviously is not tolerating it. Promotility agents can be used, we'll get to this in a minute, but things like metoclopramide, Reglan, erythromycin can be used as motility agents, especially if you have a diabetic patient with chronic gastroparesis who is not going to doesn't tolerate food very well anyway, even if they're not sick and have need enteral feedings. And then again, as we already mentioned, if they're not tolerating gastric feedings, then they can slip the tube down a little bit farther to the duodenum, past the pylorus for the toleration a little bit better. Diarrhea can be a big problem in patients. There is a tube feed that there are several tube feeds that can cause diarrhea. Impact glutamine is a tube feed that you use in pretty sick patients. Trauma patients are an example that we'll use that a lot, and it seems that it causes diarrhea in all of them. So you might notice with some of your specific tube feeds it tends to cause more diarrhea. Enteral tube feeds that have higher osmolarity, it makes sense that they're, it's going to not get absorbed as well and cause faster transit through the GI tract. And think about, does your patient have C. diff? Is your patient on antibiotics? Like, are they taking an augmentin that's going to cause them to have diarrhea anyway? And it may not be the tube feed's fault. One of the biggest things that I see is sorbitol. So if for patients who do have to get their feedings and get their medications enterally, most of the liquid medicines have sorbitol in there. So I have a lot of times, if in my neuro patients, they're having to get scheduled Tylenol, and we have to end up changing it to tablets that are crushed versus liquid Tylenol, because there's a lot of sorbitol and it can cause really bad diarrhea. You might think your patient has C. diff, but it's just because of the sorbitol content. So here's some example doses of our promotility agents. You can combine these two, but really try not to use them for a super long period of time, just because of the risk of maybe some resistance happening with erythromycin. And there's also a tachyphylaxis can happen. So basically, after you use an agent for several days, it just kind of starts working in a patient because they get used to it. So again, as I said, if I wanted you to remember one thing from this section, if your gut works, use it. Some of the best parts about enteral feedings is that it helps maintain this integrity of the GI mucosa. And so in someone who is septic and might have this bacterial translocation that occurs when they're septic, by feeding it and stimulating the gut, it actually can help be protective against some types of infection. Patients who are general surgery patients, early enteral feeding has been shown to improve outcomes in those patients, especially when you start it early and continue it. And that they really have found that early parenteral feeding really doesn't improve outcomes. And again, main thing is you need to wait 7 days, and it's if your GI tract is non-functioning. Maybe someone has a paralytic ileus. Maybe someone had bowel ischemia and is not connected and they haven't been reanastomosed yet. Those are patients you might have to use parenteral nutrition in, but really try to avoid it if you can help it. For hospitals that may not want to have a parenteral nutrition service, there are some premix parenteral nutritions that have several compartments to them, and they can kind of be broken. The compartments can be broken, and then the solution will mix. So if you're at a smaller institution where you guys don't really use much parenteral nutrition, this may be a good option for your institutions. It's interesting though, as someone who's trained in nutrition support before, as much as we like to think that customized nutrition support is the best for the patient, we really haven't found evidence to show that this is superior to standard premix. Now there are some limitations with premix formulations we'll get to in just a second, but there really hasn't been evidence, like I said. For the premix parenteral nutrition, there's really a less risk of contamination and compounding errors, but if someone's fluid restricted or they have really high protein needs, and some of the other examples that are on the slide, the premix parenteral nutrition is not going to be a great option for them. So this is where you'll have more calculations, and if I could recommend for you to practice any calculations, it's how to calculate going from grams to kilocalories per ml and kind of back and forth in terms of practicing those calculations in terms of your exam. So again, some of this is a review, 25 to 35 kilocalories per kilo per day, same thing with enteral nutrition. Now, there's a lot more literature recently for a BMI greater than 30, and especially as you get to BMIs in the 40s and the 50s, is to use something that's called permissive underfeeding, which may sound very cruel, but they found that patients, even patients who were obese with those that high, especially in 40 and the 50 range of the BMI, that you can provide this lower amount of calories based on their ideal body weight, and as long as you're giving them plenty of protein, they actually do better because you end up overfeeding them sometimes in obese patients. So there's a lot of good literature saying permissive underfeeding is what we should be doing in obese patients. Fluid, we kind of already mentioned this, the 30 mils per kilo, but another thing that you might see, and I've seen physicians order this before, stat parenteral nutrition. Parenteral nutrition is not a stat intervention. It is a feeding that they need, so if they need fluid, they don't need it. They are going to get it eventually from their parenteral nutrition, but they need to give boluses and things instead. Protein, there's a range of protein. So as our previous speaker mentioned, 0.8 grams per kilo per day is the limit if someone is protein restricted. And then up to 2, especially if someone's on CRRT that's going to remove a lot of protein off, or really high may burn patients or really severe trauma patients that have, very high severity of index of illness scores, they might need more protein. It provides about 20 to 30 calories, lipids provide about 20 to 30% of the calories as well. And then you're going to give the rest as dextrose. So remember these numbers. Protein is 4 kilocalories per gram. Lipids are about 10 kilocalories per gram, including all the different parts of the lipid emulsion, and then dextrose is 3.4 kilocalories per gram. And there is a glucose oxidation rate that I've included here for you in adults. So patients who do have hyperglycemia, you need to make sure to stay in that range. So our example we have here, if we have a 70 kilo patient, we're going to feed them 30 kilocalories per kilo. That's going to come out to 21 total kilocalories, which is where this comes from right here. Their needs are going to be 1.5 grams per kilo of protein, and so that's going to end up being 105 grams, which comes from, that's where our 420 kilocalories. Then we've already taken out our protein requirements. Then we're going to provide 25 to 30% of our total, our calories provided as lipid. So that's where it comes as 500 kilocalories. So then our remainder, you usually always do your dextrose last, because then you'll have the remainder seen that you want to give the rest of that as dextrose, and then you can come up with the amount of grams that you're going to give. So that's how you approach one of these formulas. Start with your total, do protein, fat, and then you'll end up with your dextrose. Finishing up in our last, we have about 3 or 4 minutes left. There is potential to give a peripheral parenteral nutrition if for some reason it's going to be short term and you can't place a central line. But it's really limited because same thing with potassium and other electrolytes and osmolarity of things, that you have to be very careful with the concentrations. So you'll have to keep a lower osmolarity, less than 900 milliosmoles per liter. So it really limits your amount of dextrose, the amount of your amino acids, and also the amount of calcium and potassium that you can give. So this is not used very commonly anymore. Some people may get peripheral parenteral nutrition, but it causes a lot of phlebitis, so they really don't recommend it unless necessary. One of the things to think about in terms of adverse effects, and there's lots of adverse effects of parenteral nutrition, but one thing that's really important, and the compounding pharmacist who's making the parenteral nutrition needs to be very careful with, is the risk of calcium phosphate precipitation. So if the amounts of calcium phos are pretty low in there, it's pretty low risk of having this precipitation happen. But you need to make sure that you're using calcium gluconate, being very careful with it, at least having 2.5% percentage of your amino acids. It needs to stay refrigerated, and then there also needs to be a filter on there. And then there's also a specific order, the way that you add the electrolytes into the solution. And this might be, if you work in this role, making sure that you're adding the phosphate first and then the calcium very last. Complications of parenteral nutrition, I think you guys have seen these probably before. Staph aureus, especially, and also staph epidermidis can happen very, very easily from these types of infections. And one of the scariest ones is fungemia. So if someone has a Candida albicans fungemia, it can be very scary, hard to treat, and you have to be very careful. Remove your central line, and there's a lot of issues there. Overfeeding, so some of the before we realized that we didn't need to overfeed patients who were, especially morbidly obese patients, those patients can end up having hypercapnia because as the dextrose gets broken down, that's extra CO2. Severe hyperglycemia, azotemia, and steatosis as well. And then essential fatty acid deficiency can end up, if we're not giving enough fats to patients, it can impair wound healing if lipids are withheld for several weeks. So that's something else to think about. So in terms of monitoring, and this is our last slide, making sure for refeeding syndrome, it can happen acutely or chronically in malnourished patients. And so you have to be careful in making sure you're not that they do have reduced levels of these in their body, but that you're providing them plenty of these electrolytes. Patients at risk, we kind of already talked about that. Patients alcoholic, with cancer, chronically ill. And to prevent this is when you're first starting to feed a patient, enterally or parenterally, either way, is don't give them more than 50% of their calories and then titrate it up very slow, because if you take it up very, very quickly, then it can end up causing this refeeding state. And then you're going to be providing more of these electrolytes initially as well. Finally, monitoring, this is our last slide, is you're going to be looking for infection, looking at the white blood cell, looking at the patient's port or their central line, their fluids. Pre-albumin, because the half-life is a lot shorter, an albumin half-life is 21 days, so pre-albumin is a lot shorter and can help you look at your chronic patients who are not critically ill. Glucose, electrolyte, and acid-base status, triglycerides. And then also, are they ready to start eating by themselves? Are they ready for oral nutrition? Always to be looked at. That's all I have for you guys. I'll take questions up front if you have any. Thank you.